notion of essential. How do we determine that, and what is the framework for determining that, and who determines that? I wonder if you could address that.
Yeah, so this is actually at the heart of some of the separation of powers challenges that we're seeing, as well as some equal protection challenges on the grounds that classifications of some businesses as essential or non-essential are arbitrary and capricious. I think the separation of powers challenges are really particularly interesting because they point to the idea that coming up with these lists, which state and local governments were doing on the fly in many cases, it involves a multitude of policy determinations. So those determinations are the kinds of determinations that are reserved for the legislative branch. I think what would be helpful here is law reform at the state level to adopt delegations that can be triggered by emergency declarations with statutory guardrails to allow executives to make rapid decisions in response to changing conditions on the ground, but pursuant to some guardrails that ensure that those decisions are based on the best available scientific evidence about how a particular virus is transmitted, based on various considerations and values in terms of what's sustainable long-term. I think one thing that we saw in those determinations about essential and non-essential is that there's a lot of room for various kinds of bias on the part of the decision maker to play a role in thinking through what's necessary and what's not. And so, for example, Pennsylvania described its essential business list as life-sustaining businesses, but that label really isn't consistent with a list that includes things like coal mining and dry cleaning and various other things. In the church challenges, a lot of judges found it really clever to point out that liquor stores were still open, and if beer is essential, so is church. From a public health standpoint, one thing that I was teaching public health law while this was happening, and the first thing I said to my students that night was, why are liquor stores essential? And many of them fortunately knew that that's because alcohol withdrawal for someone who is alcohol dependent is a really ugly thing and not something you want to flood your hospitals with in the midst of a pandemic. But that doesn't make it any less pithy a statement about if beer is essential, churches too. These are decisions though that can be based on how the decider lives their life. So I think they can be based on a bias toward urban living, for example, and not really thinking about how some things might be safe in rural areas that wouldn't be safe, like certain types of outdoor exercise. The Bay Area orders prohibited cycling. Which may at the time have been a concern. We maybe didn't know what the risks were in a crowded setting, but the idea that cycling would be prohibited in a rural area where you're not likely to encounter anyone is a little, not entirely based on science, and maybe a little biased toward the way of life that someone in an urban setting is used to. I think something similar applies to not doing more to think about the needs of people for whom religious worship is a significant and important part of their life. I think it's likely that disproportionately the people drafting these orders are not people for whom religious worship is a significant part of their life. I think the risks need to be addressed, but they need to be addressed in terms of the risks that are posed. And more should have been done, I think, early on to work with faith-based communities, with congregations to identify alternatives, safer alternatives to in-person worship. So for example, when we saw challenges to enforcement against drive-in services, in Maryville Baptist, it's actually not clear that the Kentucky government did enforce against drive-in services. There's a dispute about the facts there. But there were apparently some instances in Mississippi, for example, where local governments were issuing citations to people who had driven up in their own cars. That's not really based on our understanding of the risk that's posed. I think more should have been done to meet people where they are, and to recognize that social distancing is a long-term strategy. I think there was a lot of thinking that muddled the distinction between a containment strategy, which, quarantine and isolation of travelers at a time when you're really trying to keep the virus from migrating into the US from highly affected areas outside the US. That's short-term, but it requires really firm, rigid controls potentially. But it's during an incubation period for any given individual. It's a very different thing to look at social distancing as a long-term mitigation strategy for slowing the spread. I think there was a lot of misunderstanding early on that this would be for something like 2 to 3 weeks. And as it dragged out into 2 to 3 months, and as it became clear that to be sustainable, we were maybe talking about some level of more sustainable restrictions for several months and years even, I think that caused people to really rethink the kinds of ways that we might draw distinctions between what kinds of activity can be permitted, what kinds of activity must be permitted for the intervention to be sustainable long term. And I think it would have been helpful if we could have had a more open discussion about that up front in the earlier days of the crisis.
Completely agree with you on that. And I think you have a very nice article on this. Is it on the Berkeley Law website? Am I saying that correctly? Yeah, that's
Berkeley Forum is what it's called. Yeah. It's confusingly, the Berkeley Forum is actually at Georgetown University, not Berkeley.
And it discusses some of the meeting of two different factions in sort of a middle ground here, trying to understand where everyone is coming from on that. I want to pivot a little bit back to the federal response to the public health crisis. Could in lieu of sort of any kind of concerted effort here, are there any other tools that states or other municipalities have at their disposal? For instance, some states have formed coalitions to be able to provide bigger, larger leverage for whatever they need to proceed doing. I wonder if you can talk about some of the tools at their disposal right now, or can you maybe give some more insight into something like, the DPA, if that would have filled the void of what many people are looking for, especially in terms of, protective equipment and things like that.
Yeah, so let's start with the states. Early on, we saw actually some really interesting efforts to form coalitions. Interstate compacts is what they're called in a legal sense. Those were touted as serving two potential purposes. One was to coordinate negotiations for purchasing of scarce supplies, given that the federal government was largely abdicating its responsibility to think about a needs-based system for allocating scarce supplies. The other one was to give each other some cover in terms of when and how they imposed restrictions and when and how they plan to lift them. Unfortunately, we saw those compacts kind of drift into irrelevance. They're really not mentioned much anymore. They didn't do a lot of the things that they were initially touted as doing, and I think we've learned a lot from that. There's been a lot of literature about how interstate compacts could be used in this way in a crisis. I think I'd like to see some really great case studies of how they were formed and how they broke down, and how they could have been used more effectively, and things we might be able to do, structures we might be able to put into a place in advance so that they can be used more effectively. I do think, though, that those interstate compacts were relied on primarily because the federal government was not playing the role that it's traditionally expected to play. Shifting to the federal government, the DPA, the Defense Production Act, is at the president's disposal. He has made announcements that kind of went back and forth about his intentions for using it. He ultimately used it to maintain meat production and provide a little bit of cover in the form of preemption of common law tort standards of care, a little bit of immunity for the producers for claims that might be made by their employees. But it could have been used more effectively than it was, many experts feel, to ensure production of PPE, there was a lot of interest in using it for ventilators. That was a big focus early on. It's less of a focus now, as ventilator shortages, for a variety of reasons, are not the most paramount concern. But ultimately, private industry representatives reassured the president that they would do these things without the Defense Production Act coming into play. But yeah, I see the question posted in the Q&A here. That's exactly the law that is used to rapidly build warships in times of war. Important to note that it doesn't mean you get free stuff from the private sector. It's still a situation where you pay market rates, and those market rates can be extremely high. in these circumstances, but it does allow the federal government to kind of skip the line and be the first customer. I think it's possible that we've actually seen a lot of informal pressure that has achieved the same result in terms of the federal government being the first customer. We've also seen some potentially, just unclear what's been happening in terms of seizures of PPE that were en route to be delivered or had been delivered to state and local governments or private sector purchasers, with federal agents reportedly showing up on the tarmac and taking those supplies for the national stockpile, which then distributions from the national stockpile appeared to be politically motivated and not motivated solely, not driven solely by need. So I don't know that the Defense Production Act would have made a massive difference. There is a huge effort to produce more PPE. I don't know that we necessarily would want the federal government to be able to fully skip the line by using the DPA to do it under these circumstances. And Lynette, I see the other questions in the chat. Do you want me to, should we start to jump in with some of those?
Thank you.
Great. So Arthur has a question about liquor stores and churches. So he's interested in that discussion about beer in church and essentialness. Yeah, so this discussion about the risk that's posed by shopping versus the risk that's posed by a worship service, or something that's very much on my mind as someone who works at a university and is planning for fall, the risk that might be posed by classrooms. Justice Roberts, actually, in his concurring opinion, addressed this distinction in a way that I think is really helpful, a lot of guidance to executives who are crafting these orders going forward. It has to do with defining gathering in much more clear terms. This is actually something that came up in our university planning discussion just recently, like, well, what counts as a gathering? If there are, 15 pods of 7 students each across our beautiful quad outdoors, is that, 15 groups of 7, or is it one group, that's all in one place? And how far apart do they have to be for them to be definitely separate groups? Do they have to be only 6 feet apart or more feet apart, even though they're 6 feet apart within the group? Same thing for shopping, for liquor stores, for grocery stores, wherever. A lot of courts who found the prohibitions on religious worship services to be discriminatory on their face argued that at any given moment, your grocery store or your liquor store might have more than 10 people in it, right? And isn't that a gathering? Justice Roberts pointed out that there's a difference, a meaningful difference in terms of the risk of transmission between people transiently moving through a space on the one hand, as they do when they're shopping, and people spending longer duration in a space together. And that's actually borne out by epidemiological studies. So one thing that we know is as the crisis wears on, we get more information about the risks of transmission. And one piece of information we've gotten is that duration matters. And so spending an hour seems to be sort of the tipping point that's emerging. Spending more than an hour to 2.5 hours together with a group in a space, even if you are not, even if you are maintaining a distance of 6 feet among you, poses more risks than passing through a space transiently. And 6 feet apart may not be adequate to fully protect against transmission in an indoor space where you're spending a significant duration of time. Now, I think it's going to be important going forward to make those rules clear to churches. What we've seen many jurisdictions do is impose infection control protocols, social distancing protocols, density limits, durational limits may be appropriate too for church services. Some worry that enforcing those within the church or synagogue or house of worship itself could be problematic, but that's true of every social distancing restriction and every density limit restriction. Maybe a little more problematic in terms of, I guess, the potential for surveillance of the services themselves by enforcement officers. Those would typically be health officers rather than police. But I think this is a discussion that we need to have about how to accommodate the interests of people for whom religious worship is a significant need and value in their lives, and not to sort of flatly assume that religious services should be banned, but other kinds of interactions should not. I think it needs to be a very scientific, specific description of what is it that poses a risk, and therefore what is it that needs to be restricted. And let's see, we've got something on meat production, also from Arthur. Is it legally appropriate? Legally, there's plenty of authority to immunize companies from liability to their workers. Ethically, it may be very problematic. You know, I actually do a lot of work on immunity statutes. That was something I did in private practice. I also teach torts in addition to teaching health law and public health law. And one of the things that we tend to see with immunity is that it really erodes the public's trust to immunize an industry. It's actually not entirely clear whether it makes things less safe. It's not entirely clear that the threat of tort liability makes things safer, but it certainly erodes the public's trust that the industry has the interests of workers or the broader community or customers or people who might be seeking or asked to be vaccinated. It erodes their trust that safety is paramount in the minds of the people who are making decisions that have a lot of effects for the public's health.
If I could poke you on that a little bit. For the schools and, you know, any other entities that are opening up or considering reopening in coming months, how much consideration has been spent on tort liability? So for instance, person-to-person transmission within the school system or within a work environment. Is there, first of all, any claim for this, and how have the industry, or how has the industry sort of thought through this?
Yeah, so tort liability has been a big focus of discussion. I think it's been a big focus of discussion primarily because liability insurers have made it a big focus of discussion. So any given facility, whether it's a synagogue or a meatpacking plant or a university, has liability insurance, and that insurer is very interested in their plans for reopening and the risks that might pose. You know, as a tort professor, I think the likelihood of liability is not as great as some in industry groups suggest that it is. I think the difficulty of establishing causation would be a significant hurdle. Particularly where there's a virus that's circulating in the community. And so it would be very difficult, for example, to show that any given shopper contracted an infection in this grocery store. It's been a bigger issue for worker safety. So it might be easier to show causation if you are, for example, a home health worker who has not been provided with adequate personal protective equipment and yet told to report for duty in high-risk settings. Just to take one example, but there are additional hurdles there. So in addition to causation, a lot of those claims might be preempted by workers' compensation suits. I'm actually working on an article right now with a co-author, Sam Bagenstos, where we're looking at employment law, including workplace safety laws, including paid leave for sick leave and family leave, disability accommodation laws, workers' compensation, workplace privacy laws, all of the ways in which these employment and anti-discrimination frameworks affect the ability of people to follow and benefit from public health recommendations about their behavior. So that's something that we're continuing to work on now.
Perfect. Are there any other questions coming in from, I think right now we're just going to start to weave in some of the questions coming in from the
I'll let you choose or I can choose. I see actually a former student and some friends.
Oh, that's great. Oh, yeah.
Hey, awesome.
Go right ahead, yeah.
Actually, if it's okay with you, I'll jump in and say hello to Reese Kim, who is a former student of mine and health lawyer, practicing health lawyer. Reese is asking about whether recent events, both the pandemic and the Black Lives Matter movement and the horrifying events that have catalyzed the Black Lives Matter movement, what effect do they have on collecting data, the argument for collecting data on the social data? Also, how should those data be used? I think we've got a lot of data on the social determinants of health at this point. I think the time has come for action. data is important, and we need to continue to fill gaps in some of that data. For example, there are significant gaps around the role of being a member of the essential workforce and COVID risk that I'd like to see more information collected on. In addition, the risk involved in having someone in your household be an essential worker who's out and about. There are also gaps in terms of LGBT and people with disabilities and those communities, and how disparities play out with respect to the structural challenges that they're facing in our society. So there are gaps. Yes, let's collect more information, but let's not wait for more information on some of the key issues that we know are affecting people's health. In terms of action, I think a real difficulty here is that, as with social distancing, a lot of the action on social determinants of health is really in the hands of the states. And yet the states we're already facing significant budgetary constraints. And I think that is only going to get dramatically worse in the context of the economic effects of the pandemic. And so I think we have to think very carefully about our tax policy. We have to think very carefully about how federal taxes crowd out state and local taxes, how we think about the policy effects, for example, of state and local tax deductions from federal taxation to support the ability of states to provide things like early intervention for children, educational opportunities, employment opportunities, to think about providing more meaningful and higher quality access to healthcare. All of these things that what we know about the social determinants of health, what that instructs that we need to take action on now, with or without more information being gathered.
Professor Wiley, I have a quick question for you. So you kind of touched on this a little bit, but I've seen a lot of discussion about what's your overall view on just how the United States federal system can respond to a pandemic like this? There's been discussion that there's pros and cons to it, and you kind of alluded to it again in the sense of, different states can do their own parameters in terms of social distancing, but we have freedom of movement between the states. So if one state's going to do a very lax approach, and another state's going to do a strict approach, and maybe one state's approach is better attuned to the science. What's your view on this?
So I should say at the outset that I might be in the minority in my view on this. So I want to acknowledge that this is my view, but it's not the only acceptable view. As I said earlier, I think states hold the reins, and that is as it should be. I think there are good reasons for state and local control of public health interventions with respect to social distancing and a host of other measures. The reforms that I'd like to see, and I'm working on a piece right now on the impact that federalism has had on our pandemic response, and making some recommendations as part of a briefing book that a group of public health law researchers are putting together. The reforms I'd like to see is, I'd like to see more must language instead of may language in federal statutes that direct the federal support of state and local efforts. So the language in the statutes that govern the strategic national stockpile, for example, which is responsible. I mean, it's the statutes and the programs and the people who brought you the massively failed rollout of testing. And quite unfortunately, it's the same statute and programs and frameworks that are going to be charged with rolling out vaccination if and when a safe and effective vaccine becomes available. The language in those statutes is permissive. It allows the federal government to support the states. What I'd like to see is more mandatory language, essentially Congress directing the agencies to take on this role. I think that reform is needed because as it's become clear that these measures are quite costly, both because of scarcity and because of the technology that's involved with some of them, it's become increasingly clear that states do not have the capacity in a nationwide crisis of this nature to bear even primary, let alone sole responsibility for assuring these kinds of supplies. And so I think that's the major reform that I'd like to see. I really do think it's an appropriate division of responsibility for the states and local governments to make decisions. They're closer to the conditions on the ground. They are more amenable to democratic deliberation on policy questions related to social distancing, about, what is essential, what is permitted, is our goal suppression or is it mitigation? I think those decisions should be made at the state and local level. I just want to say one of my reasons for that is this distinction between containment on the one hand and mitigation or suppression on the other. There was a lot of, there was a line that got a lot of play as very clever, which was, letting states decide social distancing restrictions is like having a peeing section of the pool. And that was really smart, except it's wrong, in my opinion, when you're talking about mitigation. If you're talking about containment, if you're talking about a situation where the outbreak is limited to specific geographic areas and it really hasn't reached the rest of the country, then if one governor screws that up, if one county health officer screws that up, it can cost hundreds of thousands of lives across the country. And that's what we saw happen, which isn't to assign blame. I think the nature of transmission was made it very challenging to achieve containment. We've seen that happen in country after country. But our mindset about the need for uniform restrictions really is a containment mindset. I think it's, it's the kind of pandemics that movies are made about, where, you have to contain it in one place. And if you don't, it is immediately everywhere all at once. That's not how this pandemic has played out. That's actually not how most real life pandemics played out, right? We're used to seeing maps that turn red all over all at once, but that red all over all at once might mean there's at least one case in each state. But when we really look at where the cases are concentrated, where community transmission is most severe, it really is a patchwork pandemic, as Ed Yong's piece in The Atlantic, which I highly recommend, described it. And that's not because we messed up the response. That's, pandemics are stochastic. There's some randomness to it. They're also driven by factors other than legal restrictions. Things like, how dependent a city is on mass transit, how densely packed people are in housing units. And so how much transmission there is that's happening within the home. All of these factors that are really not about legal restrictions. And so I do think restrictions can and should vary from place to place when what we're talking about is mitigation, where you don't require perfection or uniformity. You're just trying to achieve a substantial and sustainable long-term reduction in close contacts outside the home compared to baseline. I think one of the reasons that people have been confused about what's happened as we've reopened states, although I really don't like that language of open or closed. It's not a binary, it's a spectrum or a set of dials and switches. But people sort of had this impression that, like, when Georgia and Texas first announced that they were going to reopen, there was a lot of commentary saying, well, we're going to need, travel quarantines. We're going to need to close our borders to people from those states because it's immediately going to be just a massive outbreak in those places. And when we haven't seen that, that's been confusing to people. It's made them wonder whether those restrictions were really needed. I think that has to do with misconveying what social distancing is about. It's not a containment strategy. It doesn't mean that you flip the switch and it comes roaring back. It's meant to be a long-term, sustainable, overall reduction in how many contacts are happening outside the home compared to baseline. And what seems to be the case is that even in places where the restrictions have been eased, we're still seeing a pretty significant reduction in how many people, how many people you're interacting with on a daily basis in close quarters. That is still significantly lower compared to baseline.
So I know we're going to be running out of time, and I apologize in advance to our audience. We have a ton of questions to be able to cover, but I want to encourage everyone to please continue to post these questions. What we'll do is use this to formulate another webinar. We've gotten an enormous interest in these topics. One last thing I want to sort of address really as we wind down from this webinar is, for many people have sort of thought of this as we're currently in a holding pattern and have framed it as such. We're in this for the long haul, and in many ways there is no returning back to normal, as some have said. I wonder, what do you see as some of the legal challenges for this sustained protracted pandemic that doesn't seem to be, we don't have any effective means of treatment, and we certainly don't have any vaccine on the horizon. So this is going to continue for quite some time. I wonder, what are some of the legal challenges you can anticipate on the horizon?
I think all evidence seems to indicate we're going to continue to see transmission happening, and then spikes in transmission that vary from time to time and place to place, and that might be affected by events that we can predict, but they might also be somewhat random, and we might not know when and where they're coming. In that environment, I think we're going to continue to see disputes over who is in charge. I think in particular, as we transition from the immediate response in February, March, early April to a long haul of, how do we cope with coronavirus transmission for the next, 1 to 2 or more years that it takes, not just for there to be a safe and effective vaccine, but for that vaccine to be widely distributed and accepted at the level that would be required to significantly mitigate the threat through acquired immunity. As we make that transition, I think there's a strong argument that democratic deliberation has a role to play. In an emergency response, executives hold the reins. We have emergency powers and communicable disease control powers statutes that delegate authority from the legislature to the executive to make quick decisions in real time. But when we're thinking about long-term mitigation over the course of years, I do think that these separation of powers arguments have some validity to them, that at a certain point the legislature has to weigh in. And we may not always like the results of that, but that's the system that we have. We're a democracy. The constraints on majoritarian rule have to be based on individual rights that are recognized as justifying judicial intervention. And in our system, those individual rights are negative rights. They're rights to be left alone. They're not affirmative rights to protection for health. And under that system, I think what we're going to see is more and more state legislatures provide these kinds of statutory guardrails that I started off talking about to indicate, what is the designation between essential and non-essential? What kinds of density limits are appropriate and what goes too far? And I think, we're going to have an election in the meantime, and people can express directly their views about some of the governors and county executives who have made these very tough decisions under conditions of uncertainty. But we know a lot more about the virus now than we did in February or even March. I think we'll know even more as we go into fall, and we'll have more understanding that can inform the response. I think there are going to be disputes, though, over who actually makes the call about how to translate that scientific understanding into action. Another thing that I'll just highlight is if and when a safe and effective vaccine is available, I think we're going to see challenges to vaccination. I think we're a long, long way off between any kind of general population mandate or even a school vaccination mandate because supplies are going to be very limited. But I do think we're likely to see disputes not too distant future over health workers, including nursing home workers, including home health aides, whether they can be mandated to be vaccinated as a condition of employment in high-risk settings. I think that would be, from a public health standpoint, one of the first groups to prioritize for access to the vaccine. And the question is going to be whether it can be required given the risks that can be posed, particularly to residents and patients. Residents in facilities, not medical residents, but skilled nursing facility residents and patients who are being exposed to health workers. I think that could turn out to be a particularly thorny dispute that's on the horizon.
Thank you so much, Professor Wiley. I want to extend my gratitude to you as well for taking the time out to contribute to this ongoing discussion, and to the audience for participating in your question and answer, and also for tuning in today. Again, next week we will be on a break, but we'll be returning back on June 24th at the same time with Dr. Michael Stevens, again, who is a critical care pulmonologist and he'll be speaking about healthcare on the front lines. Thank you so much, Professor Wiley. This has been a thrilling discussion. I hope that we can continue it on another date. There's so much to talk about, and again, I apologize to the audience members if your questions weren't answered. There is a lot to talk about. We will use your questions to develop an alternate time for a discussion, and perhaps we'll take a deeper dive into some of these specific topics rather than cover so nicely, which Professor Wiley did, cover such a broad swath of topics here, which can consume an entire class of indeed. So thank you again, Professor Wiley, and thank you to our audience, and we'll see you next week, in 2 weeks.
2 weeks, yeah. Thank you.
Thanks for having me.
Bye. Thank you.